Netherlands, a 29-year-old man who presented to the dermatology clinic for good reason. His normal skin coloration is this, and the entire rest is this reddish, very dark rash that involves 90% of his body surface area. And he's had this condition for several years, and it's getting worse. And we're offered in a differential diagnosis, seborrheic dermatitis, pityriasis rubra, pilaris, erythema multiforme, erythrodermic psoriasis, and toxic epidermal necrolysis. Well, this is not dandruff, so we can forget about seborrheic dermatitis. Now, pityriasis and erythema multiforme are not as dramatic as this patient's problem, at least never in my experience. And they don't just suddenly show up when somebody is 27 years old. So that leaves us with erythrodermic psoriasis, which I've never seen and hadn't really ever heard of it either, and toxic epidermal necrolysis. Toxic epidermal necrolysis is usually a sequel to a drug reaction. It's commonly deadly. It involves huge desquamation, and it doesn't hang around for 2 years. So this leaves us with erythrodermic psoriasis. So we can look at these conditions separately. This is the right diagnosis. This is a form of psoriasis that can develop from the psoriatic lesions that we clinically generally know. This patient was HIV positive, but erythrodermic psoriasis is not invariably associated with immune suppression, other than what goes along with the disease in the first place. So here are some other examples. Now, I think we would recognize this, but of course we couldn't visualize our patient close up. A generalized erythrodermic psoriasis involving large surface areas of the body occurs when oral corticosteroids that are sometimes used for psoriasis are suddenly withdrawn. Excessive alcohol consumption, other conditions are associated with this peculiar form of psoriasis. I think we would have recognized it had we seen this patient, or this patient, or this patient. I would love to see the fingernails on our patient, but perhaps we'll see them next week. This is seborrheic dermatitis, generally involves the head. Milder form is dandruff or Schuppen in German. It can become more generalized, but it's not generally a lethal condition. This is pityriasis rubra pilaris. This commonly involves hair follicles, can also be relatively severe, but looks different than what our patient has today. This is erythema multiforme, relatively common. Etiology is still not entirely clear. It has multiple forms, as the name would imply, but that doesn't encompass our disease spectrum for today. This is Stevens-Johnson syndrome in English, or Lyle syndrome. This is toxic epidermal necrolysis, abbreviated TEN. This is a deadly complication generally seen with advanced drug eruptions, but it looks different than the condition that we've just visualized. The first topic in the New England Journal is ovarian carcinoma, which is generally a severe lethal cancer of women. Fortunately, it's not too common, but if you happen to have BRCA1 or BRCA2 mutations, then the development of this ovarian carcinoma is more common. And in this example, the condition developed bilaterally, as might possibly occur if we have BRCA1 and BRCA2 mutations. The topic concerns poly-ADP ribose polymerase. This is a repair mechanism that deals with single strand breaks in DNA. And tumor DNA has to be repaired just like every other DNA. And BRCA1 and BRCA2 are repair genes. When they are mutated, the development of breast cancer, ovarian cancer, and other cancers is more common. And these tumors then rely on PARP, or poly-ADP ribose polymerase, for their repair problems. And the idea is that if we can inhibit PARP, then these tumors might be more likely to be driven into apoptosis and not proliferate further. Now, it might occur to you that inhibiting PARP, generally speaking, might not be a very good idea, because it might make one more susceptible to the development of other forms of solid tumors. And that indeed is the case. Now, olaparib is a PARP inhibitor, and it's given to patients that have triple-negative breast cancer, or people that have breast cancer associated with BRCA1 or BRCA2 mutations. And that's diagrammatically shown here. And the idea is that if, at least in the tumors, if we inhibit PARP, there'll be no repair of single strand breaks, and that these tumors might then not develop further. That's the hope. And the first study that we can look at are patients with ovarian carcinoma associated with BRCA1 or BRCA2 mutations, or rarely both. And the utility of inhibiting PARP was tested here. The PARP inhibitor is olaparib. Now, the genetic testing that was done on the patients in these studies, much of the testing was done by Myriad Genetics, that's a commercial firm, and some was also done by a laboratory in China. And as we can see here, the endpoint was progression-free survival, and the inhibition of PARP with olaparib seems to have substantial utility in that progression-free survival was decreased by more than 50%, by a great amount. Now, nevertheless, overall survival in this relatively short-term study was not shown to be different in this trial, but then the endpoint was progression-free survival. As we can see here in this forest plot, the effects in various subgroups, as shown here, were dramatic. So this therapy seems to be in a position to offer something to women that have ovarian cancer, which is generally otherwise lethal. Now, there were side effects of this therapy, but the development of additional tumors was apparently not the problem. The primary cancers did occur in both groups, but to a similar degree. Most common adverse events were nausea and anemia. Now, what was, I think, a problem in this study that was also mentioned in the editorial is that many mutations in BRCA1 and BRCA2 have been described. It would be important to know what these mutations were in individual patients to try to get some additional information in terms of precision diagnosis in these women, but Myriad Genetics refused to give this information to the investigators or to the journal. I guess this is called entrepreneurship, and I view this as a problem in this particular study. But otherwise, we have to conclude that patients with ovarian carcinoma, if they have BRCA1 mutations or BRCA2 mutations, would benefit from PARP inhibition. Whether or not this utility can subsequently be shown in patients with ovarian carcinoma that is not associated with BRCA mutations will have to be subsequently tested. The next topic involves the Bruton tyrosine kinase. This is a very interesting kinase that's present in lymphocytes and their precursors, and the kinase plays a role in lymphocyte maturation. The kinase it involves the PI3 kinase pathway with the generation of PIP2 and PIP3 that relies on the Bruton tyrosine kinase. This kinase was found to be responsible for Bruton's A-gamma globulinemia, which is an X-linked disease that was described by Dr. Bruton 50 years ago. He was a pediatrician, and he observed this X-linked A-gamma globulinemia, and subsequently it was shown that a kinase is responsible that's now named after him. Now, the Bruton tyrosine kinase can be inhibited with ibrutinib, the drug named in Dr. Bruton's honor, and inhibiting the Bruton kinase, tyrosine kinase, should have utility in B-cell lymphomas and also B-cell lymphocytic leukemia. And I thought this was already known because I believe that ibrutinib is approved in the EU for the treatment of refractory chronic lymphocytic leukemia. But nevertheless, this study was performed to test the utility of ibrutinib plus rituximab or ibrutinib alone compared to conventional chemotherapy for advanced chronic lymphocytic leukemia. And what we see here is ibrutinib did great. The endpoint here again is progression-free survival, and progression-free survival was improved by almost 100% with if we compare ibrutinib to the conventional chemotherapy plus rituximab. Now, I suppose that if inhibiting the Bruton tyrosine kinase keeps lymphocytes from maturing, that perhaps rituximab might be irrelevant in patients receiving ibrutinib, and I believe that this result would support that point of view. And if we look at this forest plot here in these various subgroups, ibrutinib was of substantial utility. Now, there were adverse events, but the difference between the two groups was not substantial. Hypertension was a side effect of ibrutinib, which I think is interesting. Infectious complications were not as prominent as one might have imagined, but the results of this study show that patients with chronic lymphocytic leukemia, a very heterogeneous form of leukemia, if they're refractory to other therapies, inhibiting the Bruton tyrosine kinase certainly has something to offer these patients. The next topic is infectious disease acquired from the environment, in this case from water supplies. And to introduce this topic, I wanted to remind you of Legionnaire's disease. The Legionella bacteria were unknown prior to a convention of American veterans in the Bellevue Stratford Hotel in 1976. And what happened here is that these veterans, almost all of whom smoked and had some degree of chronic lung disease, all gathered in the Bellevue Stratford Hotel to celebrate their victories in World War II, and there was an outbreak of pneumonia. And the pneumonia was severe and lethal. And it was difficult to make the diagnosis because the culture techniques available at the time were not particularly helpful, but the bacteria were found through silver staining of lung tissue samples. Eventually, Legionella pneumophilia was isolated. Culture techniques were developed and serological techniques were developed to make the diagnosis. And what was found is that these Legionella were harbored in the air conditioning system of the Bellevue Stratford Hotel, which stems from the end of the 19th century before there was air conditioning. So perhaps air conditioning is not always a great idea. Subsequently, the poor Bellevue Stratford Hotel, which I know very well because I went to medical school in Philadelphia, was torn down. The hotel deserved better, but that's the story of Legionella. The story for today concerns a family of bacteria called the Sphingomonidaceae, and they're also present in earth and water supplies and make interesting colonies and are in essence gram-negative rod-like bacteria that do not form spores. To my knowledge, no gram-negative bacteria makes spores, but at any rate, these bacteria have sphingolipids in their cell wall, hence the name. They have substantial utility in generating alcohol and have other metabolic aspects that are interesting. I didn't know that they cause disease, but I learned that indeed there are case reports in the literature of Sphingomonas causing disease. And here's a review of Sphingomonas posimobilis, bacteremia in humans. And if we look at these patients in this review, if we look at their underlying conditions, they're commonly malignant diseases or chronic systemic diseases that are lethal. And in this particular case report, these bacterial infections responded fairly well to conventional antibiotics. So indeed, infectious conditions with these organisms exist. But to my embarrassment, at the NIH Clinical Center, which is a big hospital in Washington, a referral hospital for unusual, mostly malignant diseases, there was an outbreak of Sphingomonas coriensis infections. And this condition is described in this article. And we see that from 2001 to 2017, there's a background of Sphingomonas infections. And eventually, more commonly recently, most of these infections are Sphingomonas coriensis. Now, the important thing to keep in mind here is that these organisms are harbored in plumbing systems. And perhaps these results would draw the plumbing system of the NIH Clinical Center into question. So if we look at these patients, since they come to this center because of severe clinical problems, mostly of a malignant nature, it's not surprising that they have underlying diseases that correspond to our bias concerning these patients. And most of them have undergone some sort of a stem cell transplant for which the clinical center is known. And these patients were infected with Sphingomonas. And actually, if we consider the severity of these patients and their clinical problems, they did pretty well with antibiotic treatment because they didn't die, with 3 exceptions here. Now, in order to generate an interesting article, we can imagine that these bacteria had to be sequenced. And that indeed was what was performed here. So there's a short paragraph on the clinical aspects of these patients. They had severe underlying disease. Most of them had undergone some sort of a stem cell transplant. They had cultures from growing these bacteria out of various bodily fluids, and isolates were made of these bacteria, and they were subjected to sequencing. So we can find, first of all, the antibiotic susceptibility, and actually, in my view, these bacteria respond pretty well to an entire panel of antibiotics that are familiar to us if we practice clinical medicine. And if we sequence these, a goodly number of these bacteria have sequences that are indicative of homogeneous isolates that were found in these patients. So these sequences were compared to reference genomes so that a clade system can be applied here to identify the phylogenetic tree of these bacteria that showed up here in the NIH Clinical Center. Now comes the detective work. Where were they? And they were in the sink, presumably in the patient's rooms. And so I think that that's a bit embarrassing for the clinical center. They'd better clean up their plumbing. So that what we can see here is that modern molecular techniques can be utilized to identify where such bacteria are coming from. Perhaps techniques of this nature might have saved the Bellevue Stratford Hotel in 1976. The next topic concerns exome sequencing. And you'll recall that exons only make up less than 3% of the total human genome. And these are the components of genes that encode for proteins. And if we confine ourselves to exome sequencing, we can cut our sequencing chore by about 97%. And that was done in this study that tested the utility of exome sequencing for chronic kidney disease. And most of these patients were recruited at Columbia University, and some of these patients also participated in other studies. For instance, a study testing the utility of statins in hemodialysis patients. And the utility of exome sequencing in terms of establishing the renal diagnosis was tested here. So we can look at these two cohorts, men and women and various ethnic groups, and in many of these patients, the underlying diagnosis was known. What was not made clear in this paper is how many of these patients actually underwent renal biopsy, so allowing us to compare the utility of exome sequencing as opposed to renal biopsy, but that really wasn't tested in this study. And if we can look at the sequencing that was performed in patients with cystic disease, glomerular disease, diabetic nephropathy, hypertensive nephropathy is sort of a wastebasket disease category. Tubulointerstitial disease is also not very precise. And then there were a number of patients that didn't harbor any diagnosis. And again, how many of these patients had undergone renal biopsy wasn't clear in this study. But what we can see here is that PKD1 showed up, PKD2 showed up, but I wouldn't think that I would need exome sequencing to diagnose polycystic kidney disease. Then a number of patients showed up with mutations in various collagens that are associated with Alport syndrome. Alport syndrome is also associated with deafness and ocular problems and has other phenotypes. Uromodulin is autosomal recessive disease that also showed up on exome sequencing, but I think that there are other features that allow that diagnosis to be made in childhood, perhaps not requiring exome sequencing, but at any rate, diagnostic variants were found in 15% of these patients that were subject to exome sequencing, and in about 7% new diagnoses were made, and the authors were delighted. What also showed up was that the APOL1 risk genotype showed up in Black patients. That's associated with FSGS, or focal segmental glomerulosclerosis. Whether or not this helps these patients to know that, I don't know. But the authors were delighted since they observed that they were able to reclassify some of their patients in terms of these genetic findings, and they believe that their findings support the utility of exome sequencing to make renal diagnoses more precise. The next topic in the New England Journal was the treatment of delirium in intensive care units. And one drug that has been around for 50 years to treat delirium is haloperidol. It's a dopamine 2 receptor antagonist, and ziprasidone is also a dopamine 2 receptor antagonist, and intensive care unit patients were randomized to either of these two drugs or placebo. The primary endpoint was the number of days alive without delirium or coma, and there are clinical tests that can be done for delirium. It never occurred to me that haloperidol would shorten the duration of delirium. We applied haloperidol to keep patients with delirium from pulling out their endotracheal tubes and their IVs and other problems of this nature. But the endpoint here was, the supposition here was that haloperidol or ziprasidone might shorten the duration of delirium or make the patients less delirious. Okay, that was not the case. And ziprasidone and haloperidol could not beat placebo in terms of days with delirium or days without delirium or coma or days in coma. There were no differences shown in this study. But what I would have liked to have known is whether or not giving these drugs would keep the patients, make them less likely to injure themselves. But the authors didn't comment on that, because I think that would be the primary utility of using these drugs. The safety endpoints, we know that haloperidol prolongs QT interval, but the one patient that had an arrhythmic event, his haloperidol had been discontinued 4 days previously, so I would think that it was probably not guilty. In terms of extrapyramidal symptoms and dystonia and problems of this nature, these are side effects that are associated with dopamine 2 receptor antagonists. So there is no difference shown in this study between these two drugs and placebo, although in my view, the correct hypothesis was not tested. So the authors conclude that there is no evidence that haloperidol or ziprasidone decrease the duration of delirium. The next topic in the New England Journal is cutaneous sarcoidosis. Not too much treatment options are available for this condition or for sarcoidosis other than giving steroids and these sorts of things. But it's known that sarcoidosis involves JAK-STAT signaling, and that cytokines are involved in the progression of this disease, and cytokine receptors characteristically signal via Janus kinases and the STAT signal transducer and activators of transcription proteins. So what was done in this case report is this poor lady here with severe cutaneous, but she also had systemic sarcoidosis. The authors treated her with tofacitinib, which inhibits JAK-STAT signaling. And what we can see here is it looks like over a long period of time, patient was observed, but these recorded events are between September 2015 and July 2018. With inhibition of JAK-STAT signaling, her cutaneous sarcoidosis got better. And if we look at, in the supplement, look at these lesions a little more carefully, they did decrease with some residual scarring that's shown here. And if we look at immunohistochemical staining of her skin in terms of expression of CD68 and the STAT proteins, that also improved with the administration of tofacitinib. Now what we would, and some experiments, these authors even did RNA sequencing, trendy, looking at these other pro-inflammatory transcripts which were reduced with tofacitinib therapy. And they also made some comparisons in terms of phosphorylation of STATs in sarcoidosis compared to a control skin disease, xanthelasmas, which are associated with lipid disturbances in normal skin. And it's clear that the STATs are elevated in cutaneous sarcoidosis. Now, we would be interested in pulmonary function because that's a major issue in patients with sarcoidosis. And actually, the authors are reticent to claim that tofacitinib improves lung function. But if we look at these results, forced vital capacity and FeV1 and carbon monoxide transfer, and actually these things got a little bit better, but the authors are very reticent to claim that tofacitinib increases lung function. Although I would speculate that tofacitinib will be tried in patients with severe sarcoidosis to test whether or not that is the case. So I think that this is an interesting little report that provides perhaps another option that we consider and that we can consider in our patients with severe sarcoidosis. Now, last week in the New England Journal, we discussed the utility of solendronate in patients with osteopenia. And that underscores the importance of this review, which reviews the topic of glucocorticoid-induced osteoporosis, which happens in all patients receiving glucocorticoids for more than a month. So their little case vignette is a 75-year-old woman with polymyalgia rheumatica, and she's been getting steroids for a long time, and her vitamin D levels are also not very good, and her T score is minus 1.2 standard deviations at the femoral neck, and basically what we can conclude here is this patient should surely receive some sort of prophylaxis from the development of glucocorticoid-induced osteoporosis. And here are the key clinical points: assessing risk, what patients are particularly at risk, utilizing the fracture risk assessment tool, considering osteoporosis, determining the T-score and what that means, and recognition that bisphosphonates are recommended as first-line treatment for osteoporosis prevention. Generally, provided that the patients have preserved renal function, and if that's not the case, we might have to consider alternatives. And here's a little schematic about the role of osteoclasts and osteoblasts and rank ligand, the development of NF-kappa B signaling, and how these cells behave, and the development of osteocytes, and avoiding their apoptosis, and etc. That's reviewed here. And then here are the guidelines recommendations, and if you treat patients with corticosteroids, you should be familiar with these, and so that you keep in mind that this prophylaxis is certainly warranted in patients so that we can protect them from osteoporosis. Here's a little question from the New England Journal. It involves a 28-year-old woman with micrognathia, dental malocclusion. She's got a temporomandibular joint problem and modestly elevated anti-nuclear antibody levels, and we're asked, what is this? Systemic lupus erythematosus. Information is a little too ambiguous to make that diagnosis. Idiopathic temporomandibular joint dysfunction. Don't think so. That shouldn't necessarily cause dental malocclusion and joint problems elsewhere. Systemic juvenile idiopathic arthritis actually has a different clinical picture. This patient's picture is not that of rheumatoid arthritis, so we're left with oligoarticular juvenile idiopathic arthritis, now in adulthood. Great guess. So that's the correct answer. Now, the patient in the New England Journal this week is a 47-year-old, basically a middle-aged woman that has bronchiectasis. She has abnormal pulmonary function tests, but COPD is not the primary problem. And her diffusion capacity for carbon monoxide was normal. The other thing that's remarkable is that she's married but has no children, implying that maybe she's not very fertile, although we'd have to ask her further. She's been treated with antibiotics for bronchiectasis, and this is a chronic condition. So she's evaluated with physical examination, and various tests are performed of pulmonary function and chronic lung diseases that could be associated with the development possibly of bronchiectasis. So a chest X-ray is done, CT is done, sputum cultures are obtained, and she has atypical acid-fast bacilli, which raises differential diagnosis in and of its own. A number of laboratory tests are done here, but they're not particularly helpful. Here's her chest X-ray. She doesn't have COPD. So alpha-1 antitrypsin deficiency should not be the diagnosis. But she has some nondescript lesions here that suggest small cavity formation, and some of this stranding and double line formation is consistent with bronchiectasis, and the presence of bronchiectasis is confirmed on this CT examination. So what is this? Is this the result of a pulmonary infection? Is this tuberculosis? I don't think so. Is this an immunodeficiency syndrome? Does this woman have X-linked A-gamma-globulinemia? Well, that wouldn't be very common in women, I wouldn't think. Is this an allergic condition of asthma, or has it something to do with aspergillus? Wouldn't occur to me. But this could be a disorder of impaired airway clearance. And if the cilia don't work to continually move the mucus forward so that we can swallow it and to remove agents out of the lungs, that might be a problem. Or if mucus production is somehow compromised. And such compromise could occur in patients with cystic fibrosis, or mucoviscidosis, as it's more commonly called in Europe. Well, CFTR mutations are generally a disease of childhood, and why this woman should have a mild form of cystic fibrosis that really doesn't become apparent until middle age might imply that she has mutations that are less common or less severe in terms of what we generally see. Cilia mutations. There's a condition called Cartaginer syndrome that is associated with bronchiectasis, but it's also associated with dextrocardia. This woman does not have that, But there are other mutations in cilia proteins that could be responsible for this condition. Well, what she has is she's heterozygous for the phenylalanine at amino acid position 508 mutation, and she's also heterozygous for another mutation, an aspartic acid for histidine substitution at position 1152. So she's a compound heterozygous for cystic fibrosis. And a biopsy is obtained, and this biopsy demonstrates the inflammation seen in small airways that lead to bronchiectasis. And then the authors discuss what the current treatment is for cystic fibrosis. And this patient was treated with ivacaftor, which deals with a malfunctioning folding that's observed in some mutations that result in cystic fibrosis, and some more modern treatments are reviewed here. So we don't commonly think about cystic fibrosis in middle-aged persons. A sweat chloride test, incidentally, was also abnormal in this patient, and the fact that she's infertile would also be consistent with cystic fibrosis. Now, the other papers that I'm going to show you today, most of them are from JMA, because the Lancet is on break. They're having holidays at the Lancet. But I think these JMA papers are perhaps more interesting. This first paper is a meta-analysis of all the things that have been given to people for osteoarthritis of the knee pain, which involves practically everybody that's over the age of 35 has some sort of knee pain and requires some sort of treatment. So here's all the treatments that are given. 22,000 patients were evaluated in this analysis, and here are all the various treatments. And all of these treatments were compared to placebo and given at least for a year. What do you think helps knee pain? The answer is nothing. How do you evaluate knee pain? That's done with the WOMAC score. There are 5 questions in this questionnaire that deal with pain, 2 questions that deal with joint stiffness, and 17 questions that deal with physical function. And this is the scale that's used to assess knee joint function. And if we look at here, all acetaminophen, placebo beats acetaminophen, antioxidants. These wonderful drugs here, strontium renalate, it wouldn't occur to me, vitamin D, cylindronic acid. Cylindronate is great for osteopenia, but it doesn't necessarily help knee pain. Hyaluronic acid, that's a favorite. Triamcinolone, okay. All these non-steroidal and inflammatory agents, not very good. And these other agents we'll discuss further. Here's something that even makes knee pain worse. Sprifermin, never heard of sprifermin, don't use it. And actually, the only things that showed up in this entire meta-analysis was celecoxib, used to help pain. But if you do a little more critical statistical analysis, this positive finding disappears. Glucosamine sulfate seems to be helpful, but not very much. And sprifermin makes knee pain worse. So what can we conclude from this? Glucosamine sulfate was consistently associated with improvement in knee pain, but the effects were small to moderate in size. All these other agents were useless. Celecoxib looked like it was better than placebo, but with critical statistical adjustments, that positive effect disappeared. And all of these other therapies you can forget. I love this next study. All of you that know me are aware of how excited I am about Genomewide Association studies. Here's a megagenomes, a GWAS study. These investigators looked at 2.4 million SNPs and looked for associations in with body mass index, waist-hip ratio, and a whole bunch of other things that are associated with cardiovascular disease, shown here. Systolic, diastolic blood pressure, LDL, triglycerides, all these fatness scores, glucose, insulin, all of the things that are associated with cardiovascular death. Now, if we look at 2.4 million SNPs, I would think that something would show up, and it did, because we already know from studies in monozygotic and dizygotic twins that all of these things here are influenced by genetic variants. So it makes sense that Genomewide Association is going to identify genetic variants that are associated with these various conditions. But if you have to do 2.4 million tests to find anything, it's going to be very unlikely that you find anything that has an effect large enough to wake people out of coma. And that was the case in this study as well. So indeed, there were findings that showed genetic association with these SNPs for all these various truncal fat, abdominal fat, visceral fat, waist-hip ratio, and all of these variables that are shown here. But all of these things have already been shown to be under genetic variants by twin studies. So here they are, and the authors are ecstatic to show with this genome-wide association. The authors say the results of this study support the hypothesis that an impaired ability to preferentially deposit excess calories in the gluteofemoral fat compartment leads to higher cardiometabolic risk in the general population. I thought we knew that. The next study deals with telomeres, and I love these. Telomeres are the tips of chromosomes, and we've known since Herman Muller and Barbara McClintock that the telomeres are important. And when chromosomes replicate, establishing telomeres, repairing them, is difficult. And there's an enzyme that's responsible for that. And this enzyme is called telomerase. And telomerase was discovered and worked up by Elizabeth Blackburn and Carol Greider. And these two women, along with an associate, got the Nobel Prize for discovering telomerase and drawing attention to its function. Now, as cells divide, the telomeres get progressively shorter. And to have short telomeres is bad. So we don't want short telomeres. Now, this amazing paper in the European Heart Journal, and if you believe this, then I have a used car that you might be interested in. This study looked at the differential effects of endurance, interval, and resistance training on telomerase activity and telomere length in a randomized controlled trial. Now, I guess that's not surprising, but this intervention only required 6 months. And that's what I find is so surprising. So what was done here is a large number of healthy people, or people that thought they were healthy, were recruited, and they were randomized to couch potato, endurance training, or resistance training, and their telomerase activity and the length of their telomeres was measured. And here are the people. Their average age around 50, men and women, and they're relatively slender, and they have normal blood pressures. Systolic's a little high in some of these, but okay. Fasting blood pressure, LDL cholesterol, and these various things are shown here. And if we look at them, I think they're pretty much in pretty good shape. They can generate a maximum heart rate of 180, not bad. VO2 max, is also pretty good. So these are pretty normal, relatively fit individual. And how fast can they run? Not bad. 10 kilometers an hour. That means that they can do a 10K race in 60 minutes. When I was 50, I could do better than that. So we'll look and see what they had to do. So here they're randomized. Control group, couch potatoes. Aerobic training. And they only had to exercise 3 times a week, which I think is remarkable. For 45 minutes, 3 times a week, sort of a walk running. Come on. 60% of heart rate reserve, that's hardly exercise at all. This interval training here is a little better with warm-up, speed, recovery, and this sort of thing. And the weightlifters, they did crunch pull-downs and seated rowings and seated leg curls, and I don't know what these things are. But at any rate, effective training, yes. After 6 months of training, the aerobic people and the interval people, their VO2 max increased, and their heart rate, resting heart rate, also decreased, and there's a definite training effect here. Now, here are the amazing things, and I cannot vouch for these methods, but the authors indicate that telomerase activity was improved with aerobic exercise, whereas with resistance exercise, it was not. And they looked at different cells, CD34 expressing cells, and faxed these cells, and then looked at telomerase activity. And they measured telomere length. And I think this is astounding because the authors claim that the telomeres got longer with merely 6 months of aerobic exercise. I think we better check this out to see whether or not it's true. So the authors conclude that aerobic exercise improves telomerase activity and increases telomere length, whereas resistance training had no effect. Amazing. We'll close with this case. This is the only case to my knowledge, although this is known by other people. This is a case of cardiac arrest by the inhalation of a deodorant spray. This patient is a 19-year-old man who was in a rehab center for drug abuse. And so in order to deal with this drug abuse and to get around this problem, he inhaled his deodorant. And he developed ventricular fibrillation. And the medics came and they resuscitated him. But they had to shock him 6 times in order to restore a sinus rhythm. If we look at this electrocardiogram, he's got right axis deviation, which I guess at a 19-year-old is probably what we would expect. And otherwise, his cardiogram doesn't look that bad, except he has abnormal ST segment and T wave changes. But I guess after having been shocked 6 times, we'll let him have that. Then we look at his labs. And CRP, not so bad. His potassium's kind of low. Sodium's 136. Creatinine, well, he had to be shocked 3 times, so we'll give him a creatinine of 133 micromoles. I love his pH, which is 7.14. They're ventilating him okay. He's got a bicarbonate of 14 and a lactate of 14. Makes sense. So he's just been resuscitated. So they kept him around in the hospital a while, and his electrocardiogram reverted to normal and his lactic acid went away. And what I learned here is that the main toxic substance in deodorant spray inhalation is butane. Butane is one of the hydrocarbons commonly used as propellants in sprayable household products. So this is a case of acute butane poisoning. I'm glad he doesn't smoke, or he might have exploded. That's it for this week. Thank you for your attention.
Vielen Dank, Herr Luft.